Hi. Hi, Beth. Disaster averted. Thank you.
Hi, everyone. So today I will be facilitating this meeting. This is my first time here, so excuse me if I just have hiccups, but I'm going to try my best to do my best here. But
I'm going to try to change my name because I didn't get my own login because I don't think I got the invitation in the first place.
Okay.
Or if you could change my name.
I just noticed that, Beth.
Yeah.
okay, so just Beth Glenn, correct?
Mm-hmm.
Okay. Perfect. Yeah, that was weird.
Yeah, I used her I used Allison's login because I don't think I was on the mailing list for this for whatever reason. So I couldn't accept it and get the link. So
Okay. Yeah, no worries. Okay. Let's see. I'm going to get us set up here.
and then I'm planning to share my screen. So can I just test it?
Yeah, perfect. If you want to go first, feel free. Yeah.
Okay.
Cool.
Perfect. Stop.
Okay, I'm going to steal it. This here. Okay. So while we're waiting, if everyone could please just drop in the chat your name, organization, and role, that would be much appreciated. And then we'll get started in a moment here. Okay, great. So it is 12 o'clock. I'm going to go ahead and start. I do know that few people will be joining us periodically, but I just definitely wanted to introduce myself as I will be facilitating this session. My name is Alex Gorey. I'm here on behalf of Julie Dang's team here at UC Davis Comprehensive Cancer Center. I'm a program coordinator. And like I said, I'm going to do my best to make things running smoothly. If there's anything concerns, feel free to send me a message in the chat if I'm doing something wrong. But yes, so we'll go ahead and get started. So I'll go ahead and move on to this next slide. So I don't know if this is something you all normally do, if we have time for it, but a quick little icebreaker. If you want to drop in your favorite flower in the chat, please do. If we want to share one, that'd be awesome. If not, we could definitely move forward too. Okay, let me see. There are folks saying roses, hydrangea, lilacs, peonies. Oh my goodness. Sweet peas. Awesome. Oh, peonies is winning. Great. Okay. Well, happy spring, everyone. So we'll just keep moving here. So just some housekeeping, general things. I know we've done a lot of Zoom meetings, so everyone should be muted. If you have a question, just please unmute yourself. Please utilize the chat box. I'll do my best to monitor that. This webinar is also already being recorded. And then at the end, I will drop in an evaluation link to everyone to take after this session, and then it'll also be emailed to you as well. Okay. All right, so this learning opportunity is brought to you by the Engaging Health Systems and Providers Work Group of the California HPV Vaccination Roundtable. So thank you to that. And then just kind of a quick overview of what we will be doing in this next 45 minutes or so. So if you haven't already, please include your introductions in the chat. I'll do my best to monitor that. And then we're going to have an amazing presentation today talking about increasing HPV vaccine uptake among adolescents and the effectiveness and feasibility of 3 types of parent reminders. And then we'll have a little bit of a Q&A session, as well as a collaborative discussion that will have an amazing moderator today, and then we'll close out. Okay, so with that, I'm going to introduce Dr. Glenn. So Dr. Beth Glenn is professor and vice chair in the Department of Health Policy and Management at the UCLA Fielding School of Public Health. She's also an associate director for the UCLA Kaiser Permanente Center for Health Equity and co-director for community outreach and engagement at the Cancer Center at UCLA. She's a health psychologist with strong training in theory and methodological issues. Primary focus of her research is the study of health disparities, and particularly the design and implementation of community-based interventions to mitigate disparities in cancer and other chronic diseases. Real quick, recent studies have evaluated interventions to improve physical activity and nutrition, HPV vaccination, and cancer screening in collaboration with community partners. So Dr. Glenn, with that, I give you control to share your screen.
Great. Thank you very much. So I'm going to put it into slideshow, hopefully. And I just wanted to say I also have with my colleague, Allison Herman, and she's going to be the moderator. And, none of this work can be done without a large team of researchers working together. So really happy to be here. If anything comes up in chat, Alex, that I need to know about, you just please interrupt me, and hopefully we'll have time at the end for questions. Thank you. So, just a little bit of review before we share some of our recent work. It's been 17 years since the vaccine was introduced in 2006. And, HPV is still the most common sexually transmitted infection, with about 13 million new infections still occurring each year in the US. HPV has been linked to about 37,300 new cancers each year in the US, and this includes the vast majority of cervical and anal cancers, about 3/4 of vaginal, vulvar, and oral cancers, and about 60% of penile cancers. So when the vaccine was introduced, as many of you were present, it was really considered a breakthrough in cancer prevention. To date, over 300 million doses have been administered, and it's really widely considered to be a safe and effective vaccine. That said, uptake in the US has been largely disappointing. And so now that it's been this many years, we not only have data from those initial studies supporting the effectiveness, but we have data from real world practice. And so this pie chart here is from a recent review by Wang and colleagues. So they identified 178 published studies from 23 different countries. And you can see here, a lot of that work came out of the US, Australia, Canada, Denmark, and Sweden. And most of the studies that were done, at least until the last several years, were focused on those precancerous outcomes. So genital, anal, and oral infections, genital warts, cervical lesions, and precancerous growths in the cervix. And so that's very important because those are interim outcomes. But more recently, and those studies have all supported the effectiveness, but more recently, we've actually seen these studies coming out that have shown reductions in cervical cancer incidence. And so this is really, what the purpose of the vaccine is, and very, very exciting. And we can see here that these are studies that were done in Sweden, Britain, and Denmark, where there is probably a higher coverage of the vaccine. And so it's easier to study cervical cancer incidence. But you can see here the earlier adolescents are vaccinated, the better of a job the vaccine does. But due to lower incidence and more complex etiology, data confirming prevention of other HPV cancers is not yet available, and that's not unexpected. So I was also going to review the history of the recommendations for vaccination. So in 2006, that is when ACIP recommended routine HPV vaccination for girls at 11 to 12. Through a 3-dose series, and with catch-up vaccination through age 26. And it wasn't until 2011 that the vaccine was recommended for routine administration to boys, and the catch-up range was to age 21. It was 2016 when they shifted really to a 2-dose series for those initiating before age 15. And then in 2019, a little bit more kind of iteration for the male recommendation. And then also this recommendation for shared decision-making for adults 27 to 45 years. So not a routine recommendation, but that suggestion that shared decision-making is appropriate. And then in 2022, as most of us probably heard, the World Health Organization kind of shifted to recommending either the 2-dose series or considering a single dose. And this is, really a worldwide consideration, not something that's currently recommended in many countries, but something that they suggest is potentially valuable. And so when we think about HPV-related cancer disparities, we know that the cervical cancer burden, which is, again, a major cancer that's really due to HPV, chronic HPV, the highest burden is among minority women in this country. So Black women, Latinx women, and then women, especially from several Asian subgroups. We've also seen racial, ethnic, and socioeconomic disparities for other HPV-related cancers. And, when we think about, these continued disparities, we can see here, this is women that had a recent pap smear in the US, and you can see that these disparities in the cancers are reflected in uptake of the pap smear. So we don't see many disparities between Black and white women, but still lower uptake among Latinx and Asian women. But when we look at up-to-date rates for the HPV vaccine, we actually see fewer disparities. So hopefully this will lead to a reduction in the disparities that we see. But we still see, kind of more disappointing up-to-date rates. But we see that Black, Latinx, and Asian youth actually have a slightly higher uptake of the vaccine than non-Latinx white youth. And so when we initially started our work, it was a partnership with the LA County Office of Women's Health. And this was back a number of years ago, just a few years after the vaccine's introduction. And we decided to collaborate with the county to conduct a survey through their telephone hotline. So they did at that time operate a multilingual hotline to help women access county services. And so we were able to use that hotline to administer a survey to parents, or mostly mothers, because it's a women's hotline, of eligible girls. And at that time, it was only girls eligible for the vaccine. And so we, spoke with around 500 mothers, and we found that 29% of the adolescent daughters had received at least one dose of the vaccine. And this was considerably lower than the rate that we saw among girls in the US at that time. And so, what we also learned from this survey was that, there was a number of potential barriers that we heard from mothers of unvaccinated girls, reasons why they hadn't got their child the vaccine that were fairly addressable. So didn't know where to get their child the vaccine, needed more information, and that these mothers were concerned about cost, even though the vaccine can be accessed by most youth, at least in the US, through the Vaccines for Children program. There was some concern about safety and side effects, but there wasn't much endorsement of some of these other barriers that were really more prominent in the lay press, like concern that it's going to kind of make daughters believe it's okay to have sex, or concerns about fertility and so on. So we collaborated with the Office of Women's Health then to implement an intervention. And so again, the hotline was used, and the operators were received some training, and they were the ones that actually delivered the education and the intervention. And so the intervention included telephone education, referral to a clinic where their child could receive the vaccine, as well as a print intervention. And the primary outcome was, receipt of the vaccine at 3 and 9 months. We also looked at parental attitudes towards HPV vaccine, which could be interim outcomes. But we didn't see an intervention effect. So there was no difference between, callers during the intervention weeks and callers during control weeks. But we did see that 40% of the adolescent girls had gotten a dose of the vaccine by the time of 9-month follow-up. And we also saw improvement in parental attitudes. So, some of the lessons we learned from that initial study, obviously 40% increase in unvaccinated adolescents could be considered a successful outcome from a public health perspective. But, why no difference between people that got that telephone education and so on, compared to those that really just got a brochure? We thought that study participation might be a nudge for parents that were in the control group to get their child vaccinated, so they didn't even need that more intense intervention. But we also know that these women face substantial barriers to accessing services in the safety net. So, we cannot give out a vaccine through a hotline. So they still have to, talk to their child's provider or find a new provider, go take their child to that clinic. And this really prompted us to shift some of our focus to safety net clinical settings where the vaccine can be accessed right there where patients are already receiving care. And so this brings us to the study that was published recently that looked at the effectiveness and feasibility of 3 types of parent reminders. And so our partner for this work was Northeast Valley Health Corporation. And I know that I see some of our colleagues here on the call today, but Northeast Valley is a federally qualified health center that operates, I think, 14 or more centers throughout the San Fernando and Santa Clarita Valley regions of Los Angeles County. We decided to focus on 12-year-old adolescents, this time boys and girls, because it's really recommended starting at age 11, and this gives them some time for them to be vaccinated after they're due, and then they felt it was the right time to intervene. And the outcome was receipt of the next needed dose. So all of the adolescents needed either their first dose or their second dose. And so when we thought about the strategies that we might implement in this study, we considered, workflow modifications. So, making sure that when adolescents come in, that they don't miss the opportunity to receive the vaccine when they're in the clinic. We also considered provider-focused strategies. Again, making sure providers give a very strong recommendation, that they get feedback on how they're doing. But then, of course, we decided on comparing the parent reminders. And so we know that there's a lot of data from promotion of other types of vaccinations, especially childhood vaccinations, for parent reminder and recall systems. But it hadn't been as well studied in the context of HPV. And this was also something that was already happening at our safety net clinic partner, and many of the safety net clinics we work with. They do use mailed letter reminders, robocall reminders, and text message reminders, but for other purposes. So we decided to select this option for this study. So the design of our study, it was quasi-experimental design. We worked with 6 clinics. And so what we initially did was we matched the clinics on the size of the adolescent population that they served, as well as their HPV vaccination rates at the study start. And then 1 clinic in each pair was assigned to either receive an intervention, which was they were assigned to 1 type of reminder, or they were put into the control group, and they didn't receive any reminders till after the study was completed. And so we had 3 usual care control clinics, and then 1 clinic receiving each of the 3 different types of reminders. They distributed a baseline reminder. Again, all the adolescents were due at the time of the study start. And then after 1 month, if the adolescent had not received their needed dose, they got a second 1-month reminder. And then we looked at follow-up after 4 months to see if they got that next needed dose, and we were able to utilize electronic health records. And so you can see here, this is what the reminders looked like. They were available for the parents in either English or Spanish, depending on their preferred language. And you can see here, text messages were necessarily very brief. We planned to mimic the text message reminder and the brevity of it for the robocalls and the letter. The letter was slightly longer because if you send people a letter and it only has 1 line of text, it looks very strange. But you can see here, very brief, just saying, your child is due for the dose. Please contact the health center to make an appointment. Related to the characteristics of the adolescents, so, it was very evenly split between boys and girls. And then you can see here, really reflecting the characteristics of the patients served at this clinic. Around 85% of the adolescents were Latinx, less than 10% were non-Latinx white, and then a combination of other race and ethnicities. You can see here the majority have Medi-Cal. Really a low percentage were uninsured, and again, these are youth, so there are quite a bit of public insurance programs for them. And then you can see here that close to 2/3 were due for the first dose, and then the remainder were due for their second dose. And at the time we started the study, it was about 58% of 12-year-olds had received at least one vaccine dose. So although for this study, we focused only on those adolescents that needed at least the first dose or the second dose at the time of the study start. And so here we see the effect of the reminders on HPV vaccine next dose receipt. And you can see here that when we look overall, so initially we looked overall, at adolescents whose parents received any type of reminder. And we see that, 12% of control parents, who didn't receive a reminder had gotten their child their next needed dose, compared to 23% of parents who received one type of, any type of a reminder. So that's 11 percentage point difference. And then we saw, although, the significant results were for the overall and then for the text message reminder, but we see that the magnitude of the effect is very similar for the mailed intervention, for the text message intervention. We see that the robocall appeared to achieve a smaller effect, so only a 7 percentage point difference. I feel like it's going on its own. But then we also wanted to look and see, was there a difference in effectiveness by child sex? And so here we can see that actually there was a much larger difference for boys than we saw for girls. So a 15 percentage point difference for boys if their parents got any of the reminders compared to control, and only a 6% percentage point difference here for girls. But then we also wanted to not only just look at effectiveness, but look at feasibility. And so what we did was, we're here kind of depicting the percent of reminders that were successfully delivered. A caution is that, we can never be sure that they're successfully delivered, but if we didn't have evidence that the email, the mail was returned to us, that the text message bounced, or that the robocall, was not answered with an answering machine, voicemail, or a person. If we didn't get data to suggest those reminders were not delivered, we assumed they were delivered. And so you can see here that overall, it's about 83% of reminders appear to have been successfully delivered. And this is the first reminder. But we see that it's only something like 67% of robocalls. So again, at the time we did the study, already, I think our phones are rejecting. Someone have a question?
Of course. Well, and that's how I felt, like the way the customer responded is like, what the fuck? It goes from messy to really messy in a hot second.
Oops, I think if you're not on mute.
So anyway, we can see here that the feasibility of the robocall was the lowest. So only about 67% of robocalls were either picked up by a voicemail or picked up by a person. And so that seemed to be the least feasible method. And then when we look at the 1 month reminder, so this is the second reminder, we see that it improves a little, and that's because they had a little bit of tracing they were able to do to double check people's phone numbers, to double check people's addresses. But we still see that robocall is the least feasible. So, kind of summary and conclusions, it was 11 percentage point effect overall. So that's, a modest improvement, but meaningful, I think. But the overall effect appears to have been driven by those text message reminders, especially, as well as the effect among boys. Again, why was there a larger effect among boys than girls? Like there hasn't necessarily been a consistent finding in the literature, but perhaps, parents of boys haven't heard about the vaccine as much. Again, there was a number of years when we didn't think about it as a vaccine for boys. So perhaps, kind of this, a simple reminder is sufficient to nudge parents of boys in a way that maybe it isn't sufficient to nudge parents of girls. Parents of girls have likely heard about the vaccine, have more likely heard about the vaccine, and perhaps it's going to take a little more to make sure their child gets the vaccine. But again, we were happy to see 11 percentage point improvement, but what would be needed to achieve a larger improvement? So, more recently, we were able to get funding from the Patient-Centered Outcomes Research Institute to do a study in which we actually compare head-to-head parent reminders. And this time we're focused on mailed or text message, given robocall did not appear to be as feasible, to clinic-based strategies. So again, including provider training and feedback, as well as reducing missed opportunities to give the vaccine when patients are in the clinic, and then a combined condition. And this time we expanded our age range from 11 to 17, and we focus on HPV vaccine completion. So this is the study that's ongoing. This was our original study design. We're actually using the stepped wedge design. So, Group A clinics, all the clinics start out in their usual care, but Group A clinics initially receive the reminder intervention, and at the end receive the combined intervention. The Group B clinics actually start out when they join the intervention period with the clinic-based intervention, and then receive the combined intervention. And then Group C, those clinics did usual care for 3 periods, but then they start out with the combined intervention. And so this was our plan. And of course, this study got funded in 2017. But of course, COVID-19 happened really at the time that we were starting those clinic-based intervention strategies only. So you can imagine, it really threw a wrench in our plans. So we were actually able to extend our project period by a year. And then we actually decided to continue the clinic-based strategy alone in the Group B clinics. And that's because, the bulk of the shutdowns and quarantine for COVID-19 really happened during that period 3 and 4. And so we got the no cost extension already to be able to continue 1 more year, and also to have those 3 clinics stay in the clinic-based intervention. And so, what we did was look, really early on at the effect of the reminders, comparing the text to the letter reminders. And, we found that the text message reminders appear to be as or more effective than the letter reminders. Again, tiny effects to start with. But we also heard from the clinic that they felt that as time goes on, text messages are so much easier to send. Now they have a third-party platform. They have the cost of postage just keeps going up. And so they decided, text messages are more feasible. Mail is too expensive. And so, and they appear to be roughly equal, or text messages better. So we decided to switch to all text messages. And this is a graphic to show, again, when COVID first happened, virtual visits are in red, in-person visits are in blue. And, as it was in almost all systems across the country, we can see here overall visits plummeted. Once things were up and running, virtual visits increased, and then, have now that hopefully we are moving out of the active pandemic period, we see virtual visits reducing. But we do know that vaccines, can't be given so far during virtual visits. So this has made our, that much more of a challenge, our study. And if we think about future trends in vaccination, we know that, pandemic-related care disruptions really did lead to reductions in, receipt of many preventive health services, right? Including childhood vaccination rates. We know this is really layered on top of pre-pandemic vaccine hesitancy that we had, been hearing more about. But COVID-19 vaccine has been administered to over 5.5 billion people in a period only a little more than 2 years. And hopefully, saving has projected to save more than 3 million lives. So, we're maintaining optimism that, vaccine-related attitudes and behaviors, will not degrade further in the post-pandemic world. But, it's kind of an unknown, I think, at this point, how, kind of how we're going to come out of this, either stronger or not as strong. So, just had a number of references that I'm happy to share, and we welcome your questions.
Okay, so with that, I'm going to steal the screen share here, and I would like to provide Dr. Herman with a well-deserved introduction. So Dr. Herman, before you start moderating, I'd like to introduce you. Okay, so we're going to talk about all of Dr. Glenn's really good work. So with that, I wanted to introduce Dr. Allison Herman, who is the Associate Director of the UCLA Kaiser Permanente Center for Health Equity and Co-Director of Community Outreach and Engagement at UCLA Johnson Comprehensive Cancer Center. Dr. Herman's primary interest is in the design, implementation, and evaluation of sustainable system-based interventions to improve health behaviors and mitigate chronic disease disparities among diverse population groups. She's committed to collaborating with diverse community members and organizations across societal sectors in this work. Dr. Herman currently serves as an investigator on numerous community partner research projects aimed at improving the health of diverse population groups, including studies aimed to increase HPV vaccination and colorectal cancer screening among safety net clinic patients. So with that, Dr. Herman, take it away.
Thanks so much for that. Lengthy introduction. I appreciate that. And thanks everyone for your time and attention. I see one comment in the chat. I would say, can folks unmute themselves? Is that an option, Alex, or not? Yeah, okay, great. So if you have a question and you would like to unmute yourself and ask that question, I would invite you to feel free to do so. I'm going to go ahead and read this first message from the chat. Michelle Miranda has shared that she's a 26-year pediatric nurse, and the most common reason for hesitation that she's seen is the fact that the HPV vaccine is the most painful vaccine that they're giving today. And rumors are circulating at school, among mothers, etc. And then folks are hesitant to come back for follow-up doses. So kind of the pain factor as a reason for hesitancy, and maybe a cause for non-completion of the vaccine series.
Yeah.
Want to comment on that, Beth?
Yeah, I did see the comment. Yeah, I think that there has been concerns about, I mean, I have heard before, opinions on right and left though about the pain, how painful the vaccine is, but also the syncope issue, I think you mentioned. I think even for my own child, when he got the HPV vaccine, of course, they don't know what I do for a living. So they're like, we're going to give them the HPV vaccine, and then we're going to make sure they sit here for 5 extra minutes. And so, I think that, and that was the UCLA clinic. So there's definitely, I think, concerns about that. I was a little concerned that they were making my son concerned about that, but anyway, he did not faint. So I was happy about that. I think that the issue of coming back for follow-up doses, I think we don't understand so well amongst those that get the initial dose, how much of not completing the follow-up doses is due to some type of resistance or just a scheduling or hesitancy or a scheduling issue. I mean, it's hard to say. I think we haven't done a lot of work to check with people and see, why haven't you come back? I mean, we haven't run into a lot of that in our own work when we speak with mothers, because part of our new study is we do speak with mothers and providers too. And I feel that I'm sure some of that failure to get the additional doses is some type of bad experience the first time, but we're not hearing it a lot. Instead, we're hearing, people are like busy, they forgot to come back. They, and also providers feeling like if the child got at least 1 dose, they even feel more empowered just to say it's time for the second dose because they know that the parent accepted it the first time. But I do think that, some of that is probably underlying the completion rates we see.
All right, I'm not seeing additional questions in the chat, so I'm going to ask one question and then, please hop in, folks. But I think it might be helpful to comment a little further on, sort of what we were thinking going into this study, sort of pitting the vaccine or the vaccine reminders versus the, system clinic level changes, workflow modifications, those sorts of things. Going in as a team, we really thought probably the clinic-based changes might be more impactful and that these reminders are just kind of a little nudge. And then the data that we're looking at shows something a little bit different. You want to talk a little bit about that?
Sure, yeah. So, we did the initial study where we compared the effectiveness of the reminders, and the outcome is receipt of the next needed dose, which is a little different than looking at rates. It's like harder to budge rates, but, so we got, that 11 percentage point bump from the reminders, but then we thought, well, I think we can do better. So then when we started our current study where we're comparing the reminders to the clinic-based strategies and the combined condition, we definitely thought that the clinic-based strategies would be more effective. We feel like when you're there in person, and we hear this from providers, then you get to look the mom or the dad in the eye and, explain why you think it's important if they have those questions, right? Or otherwise just to communicate in person how important this vaccine is versus just like having a little reminder come up on your phone or through a letter. So we definitely thought that those strategies would be more impactful. I think that, of course, is assuming that people are coming into the clinic and interacting with providers and that we're not in the middle of a worldwide pandemic. So I think that the reminders themselves in our new study, the reminders, they're not producing huge changes in the uptake of, the rates, huge changes in rates. But the fact is, I think they're more like those reminders are more likely to be successfully completed when other things go awry in the clinic. And so, although it's a small, potentially small bump up in rates for reminders, if you have the systems in place, it's probably easier to carry them out. And so what we're seeing for the clinic-based strategies, it's just very difficult in the context of all these other changes and the ever-changing nature of COVID, right? And the protections that needed to be in place in clinical settings. We kind of, as all of us did, we kind of thought, okay, well, it's going to be however long, and then the pandemic's going to be over. But it wasn't like that, right? There was like a period of time when, first it was, obviously fear of the actual virus. Then it was not as much that, but more of like, people just aren't used to, going out, and then there's workforce shortages, and those continue. And, so I think, that what has been the barrier has changed a little bit, even in the context of the pandemic, but it definitely has made it hard to carry out things that happen in the clinic. And so perhaps it's not going to be as effective as we thought initially. Plus, the whole pandemic brought up this whole issue of vaccines, right? Vaccines and mandates, and kind of a turnoff towards vaccines for some, because we wanted people to get the vaccine for COVID so badly.
Oh, we have a question from Angela. You wanna unmute?
Hi there. Thank you so much for taking my question. I'm a pediatrician in Pasadena. And my question is maybe a little bit outside of the subject of the return for a second vaccine, which was actually a wonderful study. Thank you. And this is my first time attending one of these meetings, which is wonderful. Thank you again for holding it. But my question is, our biggest hurdle in our clinic is getting the first vaccine in with the younger kids. With our patient population, we get a lot of, I know my daughter or my son well, and they're okay. They don't need this yet. Why do we need to do this at 11? Why not wait till 15? And that has been the hardest thing for me, to convince my patients to start early. And one of the things I'll tell them is, well, this is why you put on your helmet before you ride your bike, or things like that. But I wonder if you have any advice on what we can do to help increase our, let's vaccinate you early.
Yeah. That's a good question. Good point. I mean, one thing I think we are seeing more is more interest in actually recommending the vaccine for 9 and 10-year-olds. And that's just like to try to take it. And, a lot of folks would wish we could give it to, like we give the hepatitis B vaccine. We wish we could give it starting at birth, but, we don't have the data to suggest the immunity lasts that long. It doesn't make sense here. But the fact is, trying to disconnect the the sexual risk behaviors from the fact that this is a cancer prevention vaccine that we give at an early age, and also I've heard the CDC, some of our CDC colleagues talk about this. They even are okay with saying it does help, the earlier you give the vaccine, it does produce stronger immunity. So sometimes that's, I think the recommendation that you focus on, this is a cancer prevention vaccine. We get a stronger immunity when we give it at younger ages. So it's recommended for everyone, starting at age 11, and just kind of move on. And I think that the other part is just saving the more full discussion for the parents that really need it. And then for the first attempt being really, this is, a strong recommendation, your child is due for this vaccine, the way that you do recommend other childhood vaccinations. And then of course, parents that have questions, you're going to have more of a conversation about the things that they want to know more about. But I'm sure it's harder to do than I'm describing it.
No, it's actually, that's actually very true. The statement of it works better when given young. You're right. That does kind of tend to steer them a little bit better. Many of our patients will say, well, does it really work better if I do it at 11 versus 14 and a half, right before they need that third dose? And that is often where I get a little bit stuck.
Yeah, I think that, yes, no, I mean, when people put the onus back on you, I mean, yes, you don't have data to suggest exactly how much. So yeah, I think it's just I think it's more of like coming up with your spiel and giving it in a, in a confident way. And then of course you're going to have those questions. And I think you say like, I think that it's best if you do it now, but if you prefer to wait, after you've had some, discussion, then I think it's hard to, if people are going to keep asking the questions, it's hard to continue to keep up with, and still be really, honest and truthful.
Thank you.
The other thing is, oh yeah, Andrea's helping me. The other thing is to recommend, Angela, is to recommend, this is, I heard this also from my children's providers, is to give, if your child gets the vaccine before they're 15, they get 2 doses. If they wait, they have to get 3 doses. And that actually is even effective sometimes with the youth themselves. So, they don't like shots much. That's something.
No, that's definitely a good one. That gets the vaccine in by age 15 for sure in most of our patients. We have this goal to increase within our system to increase vaccinations or first vaccine given by age 11. And we've kind of hit this percentile that we're having a hard time getting over. Yeah. But yes, that is very true. I love that one. Thank you.
Yeah. Thanks, Andrea Rosales from Northeast Valley. Other questions?
Well, I know we're starting to, get close to our finishing time, but one thing I know, Beth, that you and I talked about together recently that might be interesting in the context of reminders is, and sort of conversations that we've had with our partners as well is regarding, how specific and accurate those reminders need to be.
Yeah.
So, there's you can err on the side of just blast everybody and tell them, what the requirements are, or you can make sure that you're being like very, very specific and you're sending, dear Beth Glenn, your child is due, and ensuring that child is really, really, really due for the dose. Do you have any comments related to kind of that, one way or the other? Yeah,
I know that for the first time we talked about, we did the implementation of the reminders. We worked with Northeast Valley and we came up with a very specific, kind of algorithm to make sure that we selected folks that are due. And, for that study where we're looking at next needed dose, it probably makes sense. But when you think about administering these reminders to like all the adolescents, like 11 to 17, then it gets just much trickier to try to identify like who exactly is due for a dose today and who isn't. And so for a while we were making sure we were not ever sending a general reminder to folks whose child wasn't due for a dose. Instead we send a specific reminder, your child is due for a dose, and we made sure their child was due for a dose. But, more recently we switched to having a more general reminder, like you have an adolescent 11 to 17, they can really benefit from the HPV vaccine. Can you, have you gone it yet? Can you contact your, child's provider to get that vaccine? And so I don't think we have data yet to suggest which is more beneficial, but Allison and I have laughed recently because we are getting care from two different health systems. And we recently did colorectal cancer screening. And the minute we did return our fit kits, we got a second one. So we figured out that our large health systems are not worrying about whether or not we're actually due today, but just trying to get, trying to offer and make sure that everyone that needs to get these preventive services are aware. And so I think that a lot of times it can be easier for clinics to pull off sending a general reminder that says, this is, you have someone in your family that can benefit from this preventive service. Please talk to your doctor or your clinic about getting it. So keeping it general probably makes it more doable and may not have a differential effect at all.
Great, thanks. We had one comment come in the chat. So Lizzie Hennessy had had said, with minor consent in California, are you texting the child or the adult if the child is older than 12?
Yeah, we're always texting the adult in this case. So we're focused on 11 to 17-year-olds. So this, I mean, it's exciting that we have the minor consent law in California. So far in the work that I've been doing, it hasn't been particularly helpful because we've been working, I think, with, with family practice, with primary care, and in clinics where these adolescents most often come for care with their parents. So I know there's been, some successes and being able to leverage this minor consent law, which means that, you can give the consent. I mean, you can give the vaccine to children over the age of 12 because it's part of, sexually transmitted infection management. But because we're working with primary care providers that actually provide care, usually in collaboration with the parent, we have always been working with the parent. But it's a good point. I think, if we're looking at like sexual health clinics or, even school-based settings, then there might be more ability to take advantage of that minor consent law.
Thank you.
Can I further elaborate on my question? This is Lizzie Hennessy.
Hi.
I think the concern more is around reaching out to a child who received the vaccine without their parents' consent.
Okay. Yeah.
And they don't want their parent to know. And so let's say we're then sending a text reminder that you're due for your second, and the parent's like, wait a minute, how is that possible?
Yes. So that is a really good point. I think we've always focused, we're not working in the context in which the minor goes for getting the vaccine separately. So we're only working with, when we said your child's due for the dose, it was only when we had data that was not that, that did not come from a confidential visit. So if they had received the vaccine during a confidential visit, we wouldn't have utilized that data to say you're due for the second dose. But
I see. Yeah, that makes sense.
of course, we might still be reminding parents of children whose kids got the vaccine through the confidential dose and we don't know about it. That can happen, but I think it's pretty hard to avoid that.
Mm-hmm.
But yeah,
I think there were reminders also not saying, you're due for the second dose or, a subsequent dose.
usually pretty general, at least for the most recent study. Our initial study might have said which dose. Yeah. But good point. Yeah.
Yeah, I just took a screenshot. One said is due for the first dose of the HPV vaccine. So I just assumed the other one was due for the second, but maybe you're right. Maybe it was more general.
I think for that initial study with 12-year-olds that we did use the specific reference to the doses, but more recently we haven't been doing that.
Yeah, that's good to know. So it sounds like it's not a reason for administration to delay doing this sort of outreach. The other thing I guess I kind of have in my favor is our local teen clinic, which is where teens would go and most likely access their first dose without their parents' consent, intentionally does not upload that to CARE. So the California Immunization Registry. So we aren't even able to extract that into their medical record on our end.
Yep. So causes other problems, but solves some at least.
Yeah. Thank you. I appreciate your time.
Always.
Okay, everyone, I hate to be the bearer of bad news, but we're at time. Just want to be mindful of that. But I did want to thank everyone today for attending. Here's just the future dates of next meetings. There is some information in the chat regarding registering for these meetings. We still like to continue. Registration will just register you for the entire series, which is great. Once again, thank you, everyone. I will be dropping in the chat an evaluation for this session. And when you can, just please do fill that out. Everything, like I said, is in the chat, and communications via email will also be sent. But thanks, everyone.
Thank you.
Bye.